So hello guys, the Director Medico is back with the part 2 of physiology of respiration. So in this video, we'll get to know about the lung mechanics. In this lung mechanics, first we'll discuss the airway, in which we have the conduction pathway and the respiratory pathway. And then we'll go for the clinical aspect related with this basic airway anatomy. And then we'll go with the breath cycle, and then we'll go for the muscles involved in inspiration and expiration, and also we'll discuss finally the graph related with the flow and also the volume of lung. So let's go with the first one, that is the airway. The airway being divided into two different pathways, that is the conduction pathway and the respiratory pathway. So as we all know, the respiratory pathway do contain or is the place where the gaseous exchange occur and is the functional zone. And we also know that the respiratory pathway is from the tertiary bronchiole to the alveolar sac, and that is combination of tertiary bronchiole and the alveolar duct and the alveolar sac. So the conduction pathway is having significant difference in the histological pattern or the histology of each and every conduction path. So from the nose to the nasopharynx, and then to the larynx, and then to the trachea. The trachea having the C-shaped cartilages are helpful in maintaining the lumen of the trachea. So these tracheal rings are very much important in maintaining the tracheal lumen during the expiration. This expiration is being stressed just because in expiration particularly the lumen is being helpful, the rings are being helpful for the maintenance of lumen. So this is how the tracheal rings or the complete C rings of the trachea are useful in maintaining the lumen of the trachea. So then we'll go to the incomplete rings of bronchi. So coming to the bronchi, we have one particular thing to be noted is it is the most distal part for having the goblet cells. So bronchi is the most distal part, that is starting from the nasopharynx to the bronchi. Bronchi is the most distal part which is having the goblet cells which secrete the mucus. So this is also one of the most important point from this airway concept. And so this is the airway, and then we'll go with this. So with this basic airway anatomy, now we'll go with the clinical aspect related with it. A 35-year-old patient in the emergency ward is having breathing problem. So he's having a difficulty in breathing, and he's accompanied with his wife stating that he started to cough profusely when he's eating peanuts on resting on his back. That is the supine position. So the supine position is he's resting on his back and eating peanuts. So suddenly he started to cough profusely, and this made him to come to the hospital. And the thing is, we need to know the place or the perfect location of the bronchiopulmonary segment which is being affected. So the perfect answer for this is we need to know that the right bronchus is wider. The right bronchus is wider, and the right bronchus is wider, and also it is more vertical as compared with the left bronchi. So with this basic concept of the bronchial length and the vertical position of the bronchus, we can decide that this is making a proper sense that it will enter into the right lung as compared with the left lung more commonly. And in this, we again have two different cases. The first case is upside down and the supine position. So as I discussed the supine position before, so normally when there is a patient in an upright upside position, the obstruction or the foreign particle which enters the bronchus, if it is very large, it will stop in the bronchi itself. But if it is a bit small, it can enter into the tertiary bronchi and it will go into, in the upside position, it will go into the the inferior segment of inferior lobe. But if it is a supine position, that is on bed, resting his back on the bed, so in this position it will go into the superior segment of inferior lobe. So the answer is the superior segment of right inferior lobe. The perfect answer is right inferior lobe of superior segment. So this is the clinical aspect of my video. And now we'll go with the breath cycle. So what is this breath cycle is, the breath cycle is nothing but the inhalation and exhalation, which is the main part of the today's video, that is the lung mechanics. The inhalation and exhalation. Firstly, we'll go with the rest phase. So in the rest phase, the diaphragm is in the steady state. That is the rest phase. We're talking about all the things, the inhalation, the rest phase, and the exhalation. All of we're studying in an steady state. That means a normal person with no exercise, no nothing, just watching normal video like how you're watching. So in a rest phase, the atmospheric pressure is equal to alveolar pressure. So there is, the lungs are fully expanded and they need to be expired. So now the diaphragm, the expiration is due to relaxing of diaphragm, which decreases the intrathoracic volume, which increases the intrathoracic pressure, and which automatically increase the pressure of alveoli. So this increase of pressure, which is more than the atmospheric pressure, will let the air go out of the lungs, which is called exhalation. So this is called the expiration. That is movement of air or exchange of air from the alveoli to the atmosphere is called the expiration. And what is inspiration? The diaphragm need to contract. Contraction of diaphragm will increase the intrathoracic volume, which decreases the intrathoracic pressure, which also decreases the intra-alveolar pressure. So this makes, here the pressure is less and in atmosphere the pressure is more. As we know, the air moves from high pressure to low pressure. The atmospheric pressure enters the lungs, which is called inhalation. So this is the process through which the cycle will be repeating in a steady state. And the volume which we intake or which we exhale is called the tidal volume, which we'll discuss in our further videos regarding the lung capacity and the spirometry. So this is the breath cycle. Now we'll go with the muscles involved in inhalation and exhalation, the two when it is quiet breathing and when it is exercising or forceful breathing. So in quiet breathing, the inspiration is being achieved by the diaphragm, which we already discussed right now. And the expiration is a passive process, that is the relaxation of diaphragm. So in quiet breathing, it is completely dependent upon the diaphragm, so which is being innervated by the pharynx now. So also now we'll discuss about the forceful breathing. In inspiration, the forceful breathing is very much complicated and will need to be explained in a bit proper way. So think that this eraser is a sternum and these are my ribs. And this rib which is being achieved is the thoracic ribs, or the ribs being attached to a higher level to the thoracic vertebra, and the ribs or the angles which are being blunt or anteriorly going into and attached to the sternum. So this will achieve a proper upward movement of sternum. So this upward movement is making the lungs to expand in the tangent which I drawn, that is A. And now this angle, the angles of the ribs are a bit quite downward, which increases when it is inspired. So this movement makes the ribs to contract, or which that is achieved by external intercostal muscles. So this muscle, external intercostal muscle, which is the origin is on upper rib and the insertion is on the lower rib, which contracts so that there is an uplift of sternum. This uplift of sternum is due to the external intercostal muscle contraction. So this will increase the thoracic level, or the increase the thoracic volume, which decreases the thoracic pressure, which also decreases the pressure in the alveoli and makes the inhalation process. So expiration is due to rectus abdominal muscle. So this rectus abdominal muscle will also be a quite interesting part in the expiration, due to it will allow the contents in the abdomen to be moving upward, so that it pushes the diaphragm with more force, so that it will be relaxed so fast and we can expire so soon. So this are the muscles involved in the, and also some sternocleidomastoid is also useful in expiration. So this is the part where we'll need to focus the inspiration and expiration, that are in the quiet breathing and also in the forceful breathing. And here we need to focus one more thing, which is the basic concept for our further videos, is the lung always wants to get stretched inside, or it wants to get compressed itself into a very minimum surface. And the chest wall being always wants to expand its surface and it wants to increase its volume. So this is one of the basic points which we need to remember. This is, we'll see in the further videos so soon. And now we'll go with the flow volume loops. So what is this flow volume loops? The flow volume loops is with respect to the breath cycle. So with this respect of breath cycle, now we'll discuss the normal values. Before discussing the pathological situations regarding the flow volume loops, we need to discuss that the volume and the flow are being taken in this, and the expiration and the inspiration are taken like this. So at point A, the lungs are fully expanded and having the highest volume to which it can have. And now it will, the point, when it is going to point B, this is the point B is called as expiration peak flow. So B is expiration peak flow. At this point, it is the maximum flow at which, and this is expiration. In this expiration, at point B, there is an expiration peak flow, that is the highest flow in the expiration, and this decreases when there is loss of air from the lungs. There is decrease in the volume of lungs, and then so from C till D, this is an increasing the flow. There is increase in flow, and at point D is called inspiration peak flow. So from point D to point A, it again comes to the highest. With decreasing flow, it increases the volume of lungs. So this is the inspiration peak flow. This is the normal one. Like this is the, in steady state, this is what happens in flow volume loop. But coming to the pathological situations like the obstructive lung diseases, the lung volume increases rapidly, making it's more than this, and there is a decrease in expiratory peak flow. There is decrease in expiratory peak flow, and there is no big change in inspiratory peak flow. But coming to the restrictive lung diseases, there's decrease in volumes. There is no increase in the volumes of the lung, but there is a comparative decrease. There is a comparative decrease of no big change in expiratory peak flow, but there is an considerable change in inspiratory peak flow. So this is the pathological situations related with the flow volume loops. So this is the lung mechanics finally done with the physiology of respiration part 2. So we'll be soon with part 3. Goodbye.